Thank you very much. I would like to thank the organizing committee for inviting me, and more specifically Dr. Abdulrada, who is a very close friend, and like the thank the chairperson for chairing my session. I have to say that the task I've been given now seems a lot easier after the excellent presentation that preceded my talk. But it highlighted a few points that really the outcome is based on the appropriateness of the follow-up, how close the patient are looked at, and it's mainly based on risk stratification. If you have someone who's been classified as low risk, there's no doubt that really the follow-up does not need to be very close, whereas someone who's been identified as very high risk probably needs closer follow-up. And then that's where really the local facilities and then the attitude of patients within different regions may play a major role in this perspective. With this, let me just indicate that despite really our really excellent results and the expertise of most surgeons, and then the benign nature of most of the follicular-derived thyroid carcinoma, 70 to 80% being low risk overall, there is still the recurrence of differentiated thyroid carcinoma is still reported to occur in 10 to 35% of the cases, probably higher in areas where they are served with inexperienced surgeons and centers really with minimal expertise in the follow-up of patients with thyroid cancer. And then the majority of the recurrence usually occurs within the first 5 to 10 years. And that's why I think close follow-up, especially within that period frame, is really of relevant importance. Having said this, when we design a follow-up program for patients, we have to take into consideration multiple factors. One that relates to the pre-operative stage that preceded thyroid surgery, one related to the local surgery that the patient has had and the pathology, underlying pathology that was found, the markers that really were identified, molecular markers, and then some of the elements that really were found post-operatively. And if really want to put it in a schematic way, the follow-up will consist on elements that really relate to the functional status of the thyroid follicular cancer cells, the thyroid cells, the cancer cells being similar to the normal follicular cells, being able to concentrate iodine. So we can use this feature, and that will be considered as functional staging, or we'll look at really the anatomy, the structural remnant that really is left behind, and then we need to use tools that identify structural elements, and then finally the use of molecular markers. So let me start with the anatomic evaluation. As been mentioned previously, ultrasound seems now to be the key element in the follow-up of patients. And I cannot perceive seeing really an endocrinologist or clinician following a patient with thyroid cancer not having an ultrasound machine in his office or in her office. I've been using ultrasound for the last 5 to 6 years, and I can tell you, if I don't find an ultrasound machine beside me, I feel I'm missing a large element in my assessment of the patient. And there are multiple reasons, actually, because ultrasound has been found to be quite sensitive. Actually, it's a lot more sensitive than scintigraphy. It can detect up to 2 to 3 millimeter element within the thyroid remnant or within lymph nodes. And because it has been very useful in preparing for surgery, we have been adopting in our institution pre-op mapping of neck cervical lymph nodes that we feel might help the surgeon in planning the type of surgery they'd like to perform on their patients. Similarly, we have been found that it's very useful in really identifying lymph nodes and in carrying out lymph node biopsies, which also has major implication in deciding the extent of the surgery that the surgeon would perform on their patients. Third element, really, as you know, and I will be talking about the value of serum thyroglobulin has been mentioned by Dr. Hujja. Thyroglobulin assay is hindered by the presence of antibodies that are sometimes anti-thyroid antibody present in the blood. So it can give you falsely low or falsely high serum thyroglobulin. When you do a serum thyroglobulin within a lymph node, this is not affected by the level of serum antibodies present in the blood. So this is a very useful tool, and I encourage everyone really to make use of it. And then just to go, I'll go briefly over some of the criteria mentioned by Dr. Wael before. And when you look, this is a normal normal lymph nodes. This is really the jugular-digastric lymph node, which really very commonly is one of the largest and seen normally in the neck. And usually it's anatomically close to the bifurcation of the external and internal carotid arteries. As you see, it has a lozengic, probably ovale type structure, and you can see the fatty hilum within that normal lymph node. Now, if you look at the vascularity and using Doppler, and then within that hilum, the hilum is very vascular, but the periphery is basically clear of any vascularity. And this is really what we see in normal lymph nodes, right? Now, as this has been mentioned, if you look at now this patient with papillary thyroid carcinoma, the lymph nodes are not really as oval shape as in the normal. They seem to be larger, bigger, more circular. They are hypoechoic. You look at the hilum. The hilum is not vascularized as really seen in normal lymph nodes. The vascularity is now seen at the periphery. You can see some microcalcification within lymph nodes, which really are typical of malignant involvement of those lymph nodes. And finally, in this lymph node, you can see some cystic involvement, which is pathognomic of malignancy. So you have certain criteria that can help you to decide whether really you're dealing with a malignant or with a benign lymph node. And this is all used because of the use of ultrasound. Having said this, now when ultrasound is also there's limitation on the use of ultrasound, especially when we're dealing with looking for lymph nodes in the central compartment or high up in the jugular the area, or when we're dealing in the retrosternal area. So in those cases, and especially when we're dealing with patients with intermediate or high risk, we probably have to resort to other anatomical means to identify remnant disease such as CT and MRI. Having said this, now, as I mentioned, beside the anatomical elements, we could use the functionality of the malignant follicular cells to use some tools, and the one that really is well known to majority of you is the isotope scanning, using either 131 or 123, which makes use of the fact that functional thyroid tissue and cancer tissue seems really to be responsible for the concentration of iodine within the thyroid cells, and then using whole body scanning, as mentioned by Dr. Hujja and previous speakers, using 131 tracer. Now, we have been using like less than 3 millicuries as far as for the whole body scanning, with the idea of the risk of stunning. In some centers, I know at Tawan Hospital, which is the university hospital, they have been using 123. The fact is 123 is mainly gamma emitter and then does not have the beta emission effect in destroying the sodium iodide transporters, which are believed to be the cause of the stunning effect that's seen if one performs a thyroid scan before really giving the therapeutic dose of radioactivity. Now, as has been already mentioned, there are two methods really for using giving radioactivity, either by withdrawing thyroid hormone for 3 to 4 weeks, preceded by low iodine diet for at least 3 to 4 weeks. Is also the use of recombinant TSH. The practice that has been cost-driven. Our local citizens are covered by the government, so they are covered for all their expenses. So most of them have been receiving recombinant TSH, whereas the expatriates, because of the cost, have been we have been adopting the thyroid hormone withdrawal method in their cases. But the element and I will mention about it in the subsequent protocol being used, there has been tendency in centers where they perform very successful total thyroidectomy, and I'm saying successful total thyroidectomy. They have been actually not using even recombinant TSH in the follow-up of the patient. They have been keeping the patient under thyroid suppression and looking for a serum thyroglobulin. If it really exceeds 5 nanogram per milliliter, then they would go further for further exploration and search for remnant disease. In high-risk patient, obviously, there are still some centers, especially in the very high-risk patients with evidence of vascular invasion or structural invasion, that have been, for some reason, preferring use of withdrawal, because withdrawal of thyroid medication rather are recombinant TSH in those cases, and still it's debatable, although the recent study seems really to showing not so much difference, and probably you're more expert in this field than myself. Now, Dr. Hojja had mentioned about positron emission tomography, and then using either FDG or hopefully in the future the 124 PET scanning, and it's very useful in the cases of aggressive, poorly differentiated metastatic or rapidly growing cancer, and the one specifically not avid for iodine. In some cases, and I'd say in few rare cases where they are refractory to iodine, we have like 1 or 2 cases that responded very well to octreotide scanning. They showed activity which was not present with other methods, and actually treatment with octreotide in 1 or 2 cases that we had in our series was very successful. Finally, we're coming to the tumor markers. And as I mentioned, serum thyroglobulin seems to play a major role in this perspective. Serum thyroglobulin is a very highly specific product, and has been really the value of adding the value of detecting minimal residual disease very early in the process of the follow-up of patients. The only drawback is that we have been very keen in really having the lowest level of thyroglobulin available, that physicians have been pushing for completion of surgery by radioactivity, and using sometimes radioactivity when really it's not needed. And this is my only drawback, and has been mentioned, and actually in the series that done by Schlumberger and Malik, actually 43% of the patient before going to receive radioactivity has serum thyroglobulin less than 1 nanogram. And actually, if you have someone with less than 2 nanogram thyroglobulin per mil, after stimulation with the recombinant TSH, you can be given reassurance that the patient does not have really remnant disease. And this is actually why low-dose therapy was shown to be so effective in those series. Now, few points to take into consideration. Sometimes, especially if the patient is low risk and there is no evidence by neck ultrasound of any evidence of recurrent disease or lymph node, and the patient is low risk, a low stable level of thyroglobulin does not require that really we have to be more aggressive in the searching for any other remnant disease or any consideration of any therapy. Sometimes observation with time, really 6 months, sometimes 1 year following a trend in the decrease in the serum thyroglobulin is quite adequate to highlight the fact that the patient are responding to treatment. There's no need for further investigation. One thing to keep in mind that really, as I mentioned, in 20% of the cases, especially if there is preceding evidence on pathological specimen of underlying chronic thyroiditis, or due to the presence of heterophil antibodies in the blood, 20% of the patient will have detected antithyroglobulin antibodies, which will interfere with the assay that you're using in the measurement of serum thyroglobulin. So if you're using, for instance, the immunoassay, the regular immunoassay that you're using, the thyroglobulin will be falsely low. If you're using now some of the radioimmunoassay, actually it might give you a falsely elevated level. So to deal with that, you have either to resort to some methods of really a tube dilution or pre-coating of your tube with some antibodies. But again, those are not the answer most of the time, laboriously driven. You have to probably follow the trend in the serum antithyroglobulin antibodies, and you see a trend in the antibodies going downward. This is an indication that patient probably is responding to the treatment. Finally, as mentioned in the other type of not the follicular-driven derived follicular thyroid carcinoma, medullary carcinoma, serum calcitonin, carcinoembryonic antigen CEA, serum chromogranin A, could be very useful in following those patients. Now, if you have a patient with serum calcitonin that seems stable with persistently elevated CEA, that could be a sign that probably there is a dedifferentiation of the C cell and in the thyroid cells. Now, having said this, I think I have still a few minutes. Just anyhow, but I'll be fast. Let me just give you some, it's a protocol that is adopted actually by the Mayo Clinic Center, but everyone probably, I'm sure MD Anderson, they have their own way of following their own patient. This is basically the protocol is based on the risk of really that the patient being stratified initially. So if you have someone in low risk patient, neck examination by palpation, high resolution neck ultrasound, serum thyroglobulin measured while taking thyroid hormone. Now no need for recombinant assay stimulation at 3 to 6 months postoperatively, and every year for 3 to 5 years is quite sufficient. Now we're looking at someone in intermediate risk. You add to that the fact that at this stage stimulated thyroglobulin probably would be a value added to the previously mentioned test. And the radioactive iodine whole body scan at 6 to 12 weeks postoperatively, or 1 or 2 on annual return visit thereafter. Again, neck ultrasound being always the hallmark in the follow-up of this patient, whether they are low, intermediate, or high-risk patient. Oh, sorry. Finally, in the high-risk patient, for recurrent follicular well-differentiated thyroid carcinoma, neck examination, palpation, ultrasound, stimulated thyroglobulin measurement by withdrawal, LT4 or radioactive iodine whole body scan at 3 months or annually for 5 years, along with neck ultrasound. Having said this, and I'll conclude probably with this slide, among all those tests, I just highlighted the fact the most sensitive of all those has been serum thyroglobulin. And what the drawback I mentioned about it. Now, is there a predictive way of testing for clinical outcome? Which one is the best, whether using only serum thyroglobulin, with imaging, anatomic localization, alone or in combination? And this is really a nice study, actually, looking at percent of no evidence of disease in follow-up of patient over a few years period, and classified based on low, intermediate, and high. In each category, actually, you can find that the best predictor, this in blue, is suppressed thyroglobulin less than 1 nanogram. This is stimulated thyroglobulin less than 1 nanogram in green. This is the orange negative imagings for structural disease and suppressed thyroglobulin less than 1 nanogram. And this is again negative imaging using plus stimulated thyroglobulin less than 1 nanogram. And you can see that basically the predictive value of serum thyroglobulin alone less than 1 nanogram in the low risk is really very, very significant at 84%. And then if you add other element, whether stimulated or structural imaging, it goes up to 97%. But again, the difference is not quite significant. Whereas this case is not the same when we move to the intermediate, or more pronouncedly, we move to the high-risk patient. And that's the basis of really the new guidelines indicating if you had someone who has been subjected to proper surgery, that does not apply to patient with remnant disease, okay, that had subpartial or some high residual thyroid burden within their neck, that serum thyroglobulin, even without using recombinant TSH, is sufficient along with the neck ultrasound for the follow-up of most of patients with thyroid carcinoma. And with this, probably I'll conclude and probably invite you to our next, as you know, I'm the president of the American Association of Clinical Endocrinologists, the Gulf chapter, and this would be our next year. We're contemplating our next event between October 23rd, 25th in Abu Dhabi in 2014. Last year, we had close to 700 physician and nurses attending the meeting, and it was very, very useful and of high caliber meeting. So if you have the time and you can afford, we'll be more than happy to see you at that time. Thank you very much.